І готово. Кліп, 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 і готово. Кліп.
Так, шановні колеги, всіх вітаю.
Dear colleagues, I'm greeting everyone. The satellite was indeed interesting, and I hope our section is nonetheless exciting. This is the development of the section because last year we had it already, diagnostics and treatment in ophthalmology, and today we are starting it. I'm glad to greet Professor Zborovska and Professor Droshina, and the first report by Professor Galina Ivanivna Droshina is about diagnostics of infectious keratitis. I named my lecture Mistakes in Diagnostics and Treatment because they are associated with each other, diagnostics and treatment. If we consider the factors that impact diagnostics and treatment of infectious keratitis, I have split them into two groups depending on patient and depending on physician. So what depends on the patient is late referral, self-treatment, financial difficulties, inability to afford preparations, difficult social conditions without being able to keep elementary hygiene rules, or if a patient disappears for some period, probably because of some improvement, and later decrease of successfulness and catastrophic situations when this patient might come back. What depends on the physician, it's the negative factors are little experience, inadequacy of first therapy, lack of ability to provide microbiological studies, and tests underestimation of infectious problems in those who wear contact lenses. And as well, I have not mentioned it on the slide, but I could say that self-confidence of some doctors who consider that they are almighty, but they don't try any other methods, but only those to which they're used. What are the basic requirements to ophthalmologists for diagnostics and treatment of infectious keratitis? This is the ability to collect anamnesis thoroughly, the ability to analyze the obtained data, to be aware of sensitivity of the main causes and the spectrum of action of modern antimicrobic preparations, ability to choose the term of therapy. What is required for that? One has to have a look at a number of patients, read a number of books and articles in order to understand not only which medications are helpful, but also which consequences may arise. As to laboratory diagnostics of infectious keratitis, the golden standard of diagnostics is the proof of presence of the cause of inflammation in the scrape. Different types of examinations are examining the chamber moist, the aspirate of the vitreous, biopsy of corneal tissues in some cases, scraping of conjunctiva. Additional methods of tests include PCR, which is a nice method, but pretty often our patients have co-infection. As you might see on the slide, from 25 to 52% cases, these might be fungal or viral infectious. So an experienced laboratory worker, tester, has to perform the analysis of the sample. It is necessary to scrape the edges of eyelids together with the corneal surface. The central part of the lesion as well as the edges of it have to be analyzed. And if our patient wears contact lenses, we ask him not to throw away the lenses, but test it in the lab. We also take test from the container for the lenses if possible. As far as concerned the confocal microscopy, especially on the early stages, we can say that it is a non-invasive or atraumatic method which allows to test the layers of cornea and epithelium from epithelium to endothelium. Its sensitivity reaches 94% for fungal and acanthamoeb keratitis, but on condition that it is tested by an experienced laboratory worker. This technique is low informative in diagnostics of bacterial keratitis, though. Speaking about treatment, we have to keep in mind that local antibacterial therapy in bacterial keratitis without manifestations of keratitis is of an important role. The therapy is quite a hard process, but we prescribe second generation antibiotics. Patient receives pills, and it happens so that after improvement, a patient might leave the clinics and leave the doctor after some improvement, and then recurrency can take place. So primary topical therapy has to be highly dosed with preparations of third or fourth generation of fluoroquinolones or aminoglycosides. We also use foreign antibiotics without conservations. Their frequency of use depends on the course of the disease. Correction therapy is necessary if the inflammatory process is severe. Daily examination of patients is necessary. Our foreign colleagues give advice that in small, unintense and not deep infiltrations of cornea without signs of inflammation from the anterior chamber, it is possible to use local monotherapy by one antibacterial preparation, but not less than 8 times a day. What do we use? We use antiseptics, which in forced installation regime. First 30 minutes the drops are used every hour according to the scheme shown on the slide. If one prescribes antibiotics to which the flora is sensitive, then after 2 or 3 days you will see the result. In addition, we listed medriatics, inhibitors of collagenase. If we have an inflammatory infiltration of deeper layers of the anterior chamber, spread to sclera, for example, then antibiotics usage is necessary. Fluoroquinolone of second or fourth generation, glycoproteins, intramuscular anti-inflammatory preparations, and so on. What do we supervise and monitor? We monitor the clinical picture, the decrease of size of stromal infiltration, the decrease of density of stromal infiltration, re-epithelialization of the focus, and we try to stop thinning of cornea. Even in such severe cases like these shown on the slide, if forced therapy was prescribed correctly, it is possible to treat such patient without surgery. So the lower photo shows topical therapy only drops because the patient was 31 weeks pregnant, and we could not offer anything else. And speaking about the most awful clinical pictures and pathologies which we face in our practice most often, this is hepatic keratitis. This is the zone. The total number of cases of hepatic keratitis has increased to 1.8 million patients per year. This keratitis has a number of trigger factors, the list of which you may see on the slide. And it is different from other types of keratitis because it has several clinical forms with which everyone has to be familiarized thoroughly. The most understandable classification, the most proper classification, was offered by Holland and Liesgang in 1999, and it is used by almost all our foreign colleagues. Includes infectious epithelial keratitis, stromal immune mediated keratitis, neurotrophic keratopathy, and vascularized opaqueness of cornea, as well as keratouveitis. What do we have to understand in treatment? In superficial forms, the epithelium of cornea takes place on condition of therapy. We use ointments or gels, Hansa-Clavira gel. All the rest, all the other preparations are just additional means. In topical forms, in superficial forms, one has to treat them really quickly to avoid recurrences and to avoid complications. In cases of deep stromal forms, effective treatment is possible with combination of antihepatic system therapy and steroid therapy. So the two clinical forms which I would like to highlight are stromal immune-mediated keratitis and necrotizing keratitis. This is caused by sensitivity to antigen. Its course is fast, and the progressing does not differ, almost does not differ from bacterial keratitis. The inflammatory component prevails over infectious one. So we are trying to monitor the inflammatory process in the cornea, and despite usage of systemic preparations and antivirus preparations, most often it happens so that treatment and transplantation procedures include transplantation of the membrane and keratoplastics, because we want to avoid perforation of cornea. Here on this slide there is some information about metahepatic keratitis, which is a late form of hepatic keratitis, which can also be described as a chronicle one. As a rule, we cannot diagnose a patient with metahepatic keratitis if such patient had not suffered other types of hepatic keratitis. So it implies that the structure of stroma has to be damaged, and only on this condition there can the metahepatic keratitis occur. That is why it is so important to collect the anamnesis. Hepatic ulcer of cornea can develop without any association with superficial keratitis. When at once for treatment, corticosteroids are given, sometimes combined with antibiotics. Sometimes we can treat it with non-steroid anti-inflammatory preparations and inductors of interferons, as well as long-term usage of antibiotics. In recurrent hepatic keratitis, when systemic antivirus preparations are absent or inadequate dosages are prescribed. How to diagnose hepatic keratitis? It is mostly based on clinical anamnesis criteria. These criteria are important to diagnose, and we have to pay attention to the fact that hepatic infection is one of those most common. So if you meet a patient with the keratitis, your first thought should be if it is hepatic or not. The triggers, which I mentioned already in the previous slides, have to be kept in mind. But in case if we make a mistake and prescribe false kind of therapy, and we see the recurrent conditions in our patient, we have to keep in mind that hepatic keratitis is the infection which can cause recurrency. Which mistakes could be made in treatment? Installations of corticosteroids from the first day of the disease, local usage of non-steroid anti-inflammatory means. Differential diagnostics of stromal hepatic keratitis. It takes place with syphilitic keratitis, tuberculosis keratitis, granulomatous iridocyclitis, herpes zoster keratitis with a rash on skin, keratitis as a result of virus parotitis, inflammatory syndromes with the increase of intraocular pressure, probably having viral nature. These are iridocyclitis of Fox. In stromal keratitis, the most typical mistakes are lack or insufficiently intensive short-term use of anti-hepatic preparations systematically, use of corticosteroids, non-systematic anti-hepatic preparations, and lack of attention to the condition of intraocular pressure, because 25 or 30% patients may have increased intraocular pressure, which has to be treated parallelly. When should corticosteroids be prescribed? As a rule, after 2 or 3 days of start of active systemic anti-hepatic therapy, because early prescription of steroids in absence of systemic antiviral therapy can lead to more significant damage of the cornea by the virus. And if one postpones the use of steroids for too long, it can cause loss of endothelial cells. If we prepare a patient with hepatic keratitis in anamnesis or recurrent keratitis, we have to carry out prophylactics, so which could include acyclovir in different dosages mentioned on the slide, anti-herpetic preparations systematically should be taken along with corticosteroids locally. This concerns cataract surgery and other types of surgery. Which conclusion can be made about treatment of hepatic keratitis? I can say that diagnostics of hepatic keratitis requires thorough studying of anamnesis and the knowledge, familiarization with the peculiarities of clinical picture of different forms of the condition. We have to carry out the treatment in accordance with the form of hepatic keratitis. We have to keep in mind the necessity to prevent recurrency. We've had already a lecture about fungal keratitis, which as a rule can be developed as a result of trauma by plants or animals, or misuse of contact lenses or some preparations, low immunity. The cornea as a rule contains infiltration of yellow or gray color. It may be epithelialized or not. The course is slow as a rule. Hypopyon is thick if it's present, usually of a pyramidal shape. And as I said, the mold damages the eye more dramatically. Speaking about treatment of fungal keratitis, here is a list of anti-fungal preparations. Only those preparations which have their molecular mass less than 500 could be more effective, and they may be used for epithelialized cornea, whereas other preparations with molecular weight over 500, they do not penetrate the epithelium, and one has to perform scarification of cornea. Speaking about acanthamoeb keratitis, in severe cases, it threatens with development of blindness. In Europe, there is from 1 to 9 cases of 100,000 cases. The risk factors are swimming in contact lenses, not following hygiene rules, staying under the rain. What should I say about this type of keratitis? It has a long-term development. This is not an instant infection. That is why it can have the course with different acute stages. But the first stage concerns only epithelium, which might be like dirty and cause the phenomenon of discomfort. The second stage is damage of the superficial layers of stroma. So in order for the infection to get inside the stroma, 3 weeks is required. So it takes 3 weeks for this penetration to the superficial layers of stroma. So that is why timely referral to confocal microscopy is of crucial importance. We cannot receive the information from which we could receive from confocal microscopy from any other source. The third stage is ring-shaped infiltration in stroma. It takes 6 weeks for it to develop. Fourth stage, it's the ulcer on cornea, condition of after 10 weeks. Differential diagnostics of hepatic keratitis as differed from acanthamoeb keratitis. It has multifocal nature of epitheliopathy, acute pain, which is non-characteristics for the clinical picture that you might see, and presence of risk factors, contact lens wearing, contaminated water use, even in case of washing face in the country house. Why am I focusing your attention on acanthamoeb keratitis? Because it is often not differentiated from Pseudomonada 1. Both keratitis are occurring most often in patients with contact lenses. Both conditions may ruin the epithelium layer. But we have to differ them somehow, right? But the second condition is characterized, like the pseudomonade keratitis is characterized by urgent start and very speedy course. Hypopyon may be formed on the third or fifth day after the onset of the disease. This slide shows our patients on the left, acanthamoeb keratitis, and pseudomonade keratitis on the right. So the lower pictures show 2 months immune ring, and abscess with hypopyon is seen on the last photo. The photos show third, fourth, and fifth day. Treatment is different in acanthamoeb keratitis and Pseudomonas keratitis. If we have opportunity, we use Brolan and voriconazole, additional therapy, analgetics, or nidazole. Pseudomonas keratitis should be treated by aminoglycosides of the second or third generation, fluoroquinolones in forced regime of instillations with additional systemic therapy. One has to remember that the goal of treatment is to destroy the bacteria or viruses or fungi. So everything has to be well thought in order to remove the threatening factors from the cornea. We have to avoid wrong decisions in treatment, which would increase pathogenicity. And the following question is, how long should we treat conservatively? In absence of positive dynamics, and in case of the corneal condition worsens, we have to take surgical measures. We have to use intrastromal injections. Usually it happens in fungal keratitis, surely avoiding perforation. And in case of speedy progressing course, we have to apply surgical treatment. Which are the indications for surgical treatment? It's superficial keratitis, which does not tend to decreasing the area of the ulcer of cornea, non-controlled progressing of purulent infiltration despite intensive medical therapy, deep stromal keratitis with progressive decrease of visual acuity, resistant to treatment for 2 or 4 weeks, destruction of stroma which types of keratoplasty are performed, very different types, from the penetrative one to flap transplantation. If penetrative keratoplasty allows to remove the infection from the cornea completely and to wash the anterior chamber, in some cases we may perform layer by layer keratoplasty. Sometimes after sanation of the anterior chamber. But we don't have to address it either too early or too late when the disease spreads to the posterior chamber. I would like to focus on the use of biological coverage, which unfortunately is most often used for perforations over 1.5 millimeters. Biological coverage does not hermetize in such large perforation, and the flow of the chamber moist continues and secondary glaucoma may occur. So the basic indication is infiltration of flap wounds, burns, inflammatory diseases without obvious perforation exceeding 1.5 millimeters. What do we locally use in post-surgical period? We use antiseptics, antibiotics, artificial tears without conservatives. We use systemic medication treatment. So my program is for 30 minutes, but I'm finishing already. So the prognosis of treatment of acanthamoeba keratitis and pseudomonade keratitis depends on timely diagnosis and the terms when adequate antimicrobial therapy begins. Forced and long-term installations of antibiotics and anti-amoeba preparations which toxically impact the epithelium should have positive impact on the all over on the total process of treatment. So, general conclusion, I would like to say that treatment of patients with infectious keratitis has to take place taking account the etiology, the stage of the inflammatory process, and the severity of the disease. Surgical treatment has to be timely, high level of surgical specialty has to be present. Thank you for your attention.
І секції у нас
Thank you very much. I hope that we will have questions at the end of our section. So our next report of Professor Zborovska Alexandra Volodymyrovna, vascular impairments of retina, such similar and such different. So please, you're welcome. Good idea. Mike, please. Good day, dear colleagues. Today we will talk about vascular impairments of optic nerves and of retina. They are really very similar and very different. So let's talk with the simplest one, with ischemic neuropathies. Any human being can be affected, can suffer even if there is a discopathy. Hematologic diseases, amount of hematologic diseases increase right now. And now in scientific literature there is a term uh, artery and non-artery ischemic neuropathy. Artery connected is associated with the temple artery read. I want to pay your attention that there is an image of ocular nerve, optic nerve, and visual acuity is very high, and but the image of impairment is like this, and also fields of vision are preserved, and optic disc uh, have has the same image when a human being has a brain tumor and diabetic neuropathy, especially with the diabetes mellitus of the second type, especially when a person doesn't know that he suffers diabetes, and you know that very often diabetes is the first person who establishes diagnosis of diabetes of the second degree, and very often the first sign is diabetic neuropathy, so please remember about it. Thrombosis of central vein of retina and its branches. We are well known the reasons. It's a classic image, well known. I want to pay your attention. There is thrombosis of central vein of retina. It can be associated with the drusis of optic nerve. So if you have a possibility to investigate optic nerve after the treatment of hemorrhages in order to prevent rethrombosis and recurrent rethrombosis, please pay your attention to optic nerve or to bare eye, because very often druses are the problem of both eyes. I want also to tell you about antiphospholipid syndrome. It's um, quite young pathology. Our predecessors have the possibility to investigate ocular fundus not so long ago. Compared to the surgeons, we had this possibility in the mid of 20th century. AFC is autoimmune thrombotic vasculopathy, and very often it is substituted and confused with a classical thrombosis. Different vessels of different sizes are impaired. Big vessels, small arteries. These thrombosis are non one time, they are repeated. Thromboembolia of small vessels, of pulmonary vessels. Repeated strokes and repeated heart attacks. So please be very attentive when you gather past history, neurological pathologies, and AFC can be manifested by can have skin manifestation. It was described firstly in 1986, and now we try to collect the knowledge about this pathology, and scientists don't understand whether it is a primary manifestation of systematic lupus erythematosus or it's a separate disease. So you can see the picture, and it looks like the thrombosis of central vein of retina. The secondary can be primary and secondary. When people have been established systemic lupus erythematosus, then Sjogren disease, rheumatoid arthritis. It can be a secondary impairment when a person suffers malignant neoplasms, infectious mononucleosis, HIV. Here you can see the image of patient with AFC. It was our first patient. We established this diagnosis. This patient got treatment not against AFC but against ischemic neuropathy. We enrolled him with such white spot on optic disc. So I want to highlight that there is no diagnosis chronic thrombosis, because thrombosis is an acute condition. There is no chronic thrombosis in any cases, in any dispositions. So there is no such a diagnosis, but it was established and it was noted. In such, at that time, there was information in literature that the sign of posterior neuropathy is a negative rejection on dexamethasone injection. So if you inject dexamethasone and his condition worsens, he has neuropathy. And the thing was that he had this severe reaction on dexamethasone. He was administered pelabulbary. We stopped treatment, and he didn't get any treatment. At the beginning, he had increase in visual acuity, and then it was recurrency. Then he made tests, and we got such test results. They are positive for AFC, and he got treatment against AFC with a rheumatologist. Now, only rheumatologists are involved in treatment of AFC. Here you can see the scraping analysis for systemic lupus syndrome and in other systemic syndromes. And that is why they are usually connected. Another one interesting pathology is thrombophilia. We have such a patients, and their number is growing with the impairment of retina associated with the thrombophilia. It's a heritage disease. In previous years, this disease was a problem of pregnant women, of pregnancy, but now the influence of thrombophilia is studied very precisely. It's recurrent venous thromboembolia, then venous thrombosis up to 40 years, venous thromboembolia in relatives, and thrombosis in non-usual locations, cerebral thrombosis, kidney thrombosis, and liver thrombosis. You can see that it can be provoked by the lack of proteins C and S. Our task is to refer the patients to a rheumatologist, and rheumatologists should decide the type of these thrombosis disease. Also, it's our patient with thrombophilia. First diagnosis was chronic thrombosis at his local polyclinics. So when he was referred to our polyclinics, and here you can see hemorrhagic retinopathy with ischemia. We are forming now tactics of treatment because we have only few such patients, but there is some tendencies that unite those patients. What about vascular impairments caused by uveitis? It's not an inflammation by choroid. It's the term of perivasculitis. These are uh, periphalbitis, and we can see them when people suffer multiple sclerosis, sarcoidosis, Behçet disease, sparse planitis, and shotgun. Perivasculitis, it's a proper name, but retina is also involved in this process. It also causes the edema of retina and decrease visual acuity and vision in general. And the severest impairment is impairment of iris. Arthritis are characterized for systemic vasculitis and acute necrosis of retina as Irvan syndrome and multiple sclerosis with impairment of cerebral veins. So we change our point of view as to the pathomorphosis. And there is a very rare pathology, Irvan syndrome. Predominantly young women suffer it. It's a type of arthritis. So you have to investigate fundus of those patients, and practically in all cases the location is periphery and then center. I want to pay your attention that we have patients with malignant tumors, with lymphomas, leukemia, with viral infections, and they have acute retinal arthritis, and you can see the picture. You can confuse it with TB because TB retinal vasculitis looks like lymphoblast leukemia. Yeah, you can also confuse TB with ILSA disease. There are publications that have an information that ILSA disease is the manifestation of allergic response and TB. So there is no new diseases. We have new manifestations of all diseases, and all at the beginning of 20th century, TB was the most severe infections, and it provoked a lot of manifestations and complications. Here in this table, you can see the vessels that are impaired. So, colleagues, please pay attention on past history and on systemic diseases. I understand that it is very difficult. I understand that you have to gain new knowledges, but you may be the first people, for the first responders who will save the life of people. You may establish the diagnosis not only of diabetes by leukemia, HIV. Of course, you have no right to establish, but you may refer this person to the proper specialist who will be involved in it. And of course, please pay attention on iris dilation because a lot of vascular impairments begins on periphery, and of course we have a question of treatment. Of course, treatment differs depending on the etiology, but our main task is to support and to preserve our vision. All these processes causes neurodegeneration and ischemia. They all causes thrombosis of the central vein of retina. It's a type of stroke. If you have ischemic impairment, we are talking about stroke because it is understandable for our patients. That's why we have to preserve the vision and preserve the functioning of retina and on vessels. Of course, those patients are chronic. These are chronic patients who have to administer treatment on a constant basis. And in our country, we have such a situation that ophthalmologists are involved in the process of treatment, because in other countries, if a patient has a ischemic disease, he goes to the cardiologist, but our patients come to us, to ophthalmologists. So we have to support people in general, and we have to use complex medications. I am involved in treatment of chronic patients, and they don't want to take a big amount of medicines, and we have also evidence-based medicine. So the combination of erythritol with RX formula have anti-inflammation and anti-ischemic effect, and plus omega-3. And if you have listened to my lecture on pigmentous retinitis, now it is treated with omega-3. It was really a crucial opening for me. So pigment retinitis is also treated in our department, so that is why I want to highlight one more time resveratrol, then vascular action, vascular effect, and inflammation effect together with IRIDS2 and omega-3. It was an opening for me. It's retin, daxantine. And what about problems in treatment? Janus effect. You can see the statue of Janus. Why we can see this image? The main problems, main mistakes. All these medications that we use in the treatment of vascular impairments, corticosteroids, they have Janus effect. If we use them timely and they are prescribed to patients in a proper manner, we use them in a proper combination and urinated at first, then corticosteroid, and then for expansion of vessels. I'm talking now about the consequences of usage. If you use them prescribed in timely manner, you will have a positive effect. If it is done not in timely manner, these medications can impact can have a bad impact on the condition of our patients. And unfortunately, we all of us have this negative experience. And that's why we form our own tactics of treatments. For example, corticosteroids at AFC. If we don't remember about this AFC, we will make a harm to a person. And then we should use neuroprotectors, antioxidants, and medication prescribed by rheumatologists and cardiologists. We have to refer patients also to hematologist and rheumatologist, and to control people if they take prescribed medications, because if there is no control of thrombosis of this blood component, you won't be able to reach an effect. The same situation with neuroprotectors, anti-ischemic, and other medications. And the main problem is the absence of treatment in general. We have also such a situation. I have such a rule in order to save both my time and my patient's time, as well as my colleague. Previously, I ask patients to make tests because due to my clinical experience, I know what they should make, because I can know in advance the pathology. Unfortunately, there are some tests in Ukraine that are not performed. Some people can do it abroad. Thank you for your attention. We will have another one.
Доповідачів.
We're going to have another report now, and then we'll listen to questions and answers. The next report is by Korol AR, and the name of it is Mistakes in Panretinal Laser Coagulation for Diabetic Retinopathy. Why does it fail? Dear colleagues, greetings to you. So before discuss where the mistake is when performing laser coagulation for patients of diabetic retinopathy, a couple of words about the mechanism of its action. When we coagulate the retina, we decrease the area of retina which requires blood supply and decrease the ischemia of this part of retina. We improve the diffusion of oxygen through coagulates, and we decrease the ischemized retina area, decreasing the neovascularization. At present, even with development of antifreeze therapy, laser coagulation in diabetic retinopathy is the gold standard for treatment. Nobody has cancelled it, and I'm sure nobody will. What are the indications for laser treatment? We know that pre-proliferative stage and proliferative stage of first, second stage, anterior panretinal treatment, laser treatment, rubeosis of iris, or in the angle of the anterior chamber, which are signs of big scale damages of the retina. In third, fourth stage of severity of proliferative retinopathy and recurring hemophthalm, laser treatment is indicated. This is our scheme of laser coagulation step by step. Definitely you may have your own methodology, but it's the main point. You have to have your own methodology. Each patient has to be treated according to yours. As we know from the scientific literature papers, the laser coagulation depends on the stage of diabetic retinopathy and the type of the diabetes. For example, in pre-proliferative stage, beginning laser coagulation, it is the most effective with both insulin dependent and insulin independent case. If we start our treatment in proliferative stage, the effectiveness of treatment decreases to 42%, and such patients undergo vitrectomy. Another reason of failure of laser coagulation is that insufficient area for coagulation is chosen. It always we always choose a proper diameter for coagulant. The mistakes in calculation of coagulants, in choice of contact lenses. I'm sure that you know that every lens has its own optical parameters to increase or decrease the parameters of coagulant, which can impact the area of the performed laser coagulation. Thus, we know that classical panretinal laser coagulation requires to be performed at about 264 square millimeters in light stage. And if you are able to perform laser treatment on more modern and advanced technique like Novelas, then such laser coagulation requires twice more coagulates, 2,200 as minimum, and up to 7,000 in severe stage. These data were obtained during Manchester Pascal study. Also, one of the failures, sometimes failures may be caused by improper beginning of coagulation. If it doesn't start in pre-proliferative stage, but in the proliferative stage. Improper choice of tactics, improper assessment of severity. If physician has not found neovascularization, for example, or rubeosis of iris, then his patient might have secondary glaucoma and impairment of visual functions. So generally accepted shots, the interval between them has to be about a month. Taking into account fast and speedy development of anti-freeze therapy, It is used in modern ophthalmology. We have to know that, first of all, any anti-frizz preparation of any generation produced by any manufacturer, these means remove proliferation. They move the proliferation component of retinopathy. As to the effect of preparation proliptonate, if you remember, we used to have it in Ukraine in 2009, 2010. A study showed that in regular use, this preparation causes closure in
Було що
62% eyes,
операція.
whereas
Після
37%
припинення
eyes
використання
do not
препаратів через 16 тижнів
achieve
відбувається
closure.
рецидив неовострізації.
37%
Біля 40% пацієнтів
have recurrent neovascularization. So you have to understand that anti-frizz preparations do not secure 100% effect.
Інше дуже цікаве дослідження,
Another
в якому проводилось
exciting
порівняння монотерапії
study
і
was about
монотерапії
the
лазерної
outcomes of
коагуляції.
eyes
Потім
lost to follow up with proliferative diabetic retinopathy that received panretinal photocoagulation versus intravitreal antivascular endothelial growth factor. You can see the table on the slide, which shows neovascularization of iris and tractional detachment. The number of cases in the group of anti-frizz preparations, there weren't any specific preparations, but there were just those available at the time. So you can see the number of successful stages. What do we see from the result? As to visual acuity of patients, it was the lower graph shows the visual acuity. So if a patient after laser coagulation just disappeared from the clinics and failed to come back, this means that 5 injections were enough for him to support and increase his visual acuity level. Another study, Protocol S, studied the impact of ranibizumab on patients with the loss of follow-up. So the group of patients who disappeared from follow-up, 40% of them had neovascularization with the optical nerve disc and tractional detachment, 33%, which was significantly higher than that in the group of ranibizumab with the loss of follow-up than in the group of patients with laser coagulation. Meaning that it is proper to combine laser coagulation with anti-frizz preparations when recurring hemophthalm, for example, partial hemophthalm with fresh, newly formed hemophthalm, in case if it is impossible to perform laser coagulation. During laser coagulation, in presence of diffuse or complicated diabetical macular edema, the use of these preparations is also advisable. In combination with laser coagulation. After complete performance of it, we observe full fully newly vascularized vessels which grew, and we decided to administer inhibitor of the preparations. So as a result, I would like to say that laser coagulation of retina is pathogenic, standard, and first choice means to fight neovascularization in proliferative diabetic retinopathy. To achieve the effect from the laser coagulation, a certain number of laser coagulants has to be used at a certain stage of diabetic retinopathy. Thank you kindly for your attention. Dear colleagues, I have a couple of minutes. We have 15 minutes for questions, if you have any. Will you perform laser coagulation in case of ischemia with the significant zones of ischemia without soft exudates? Is it an indication for laser coagulation? No, this is not an indication for laser coagulation. More severe proliferative form is, but there are different classifications. We use the one where pre-proliferative one, but at the same time it is called highly severe retinopathy. As what concerns OCT, OCT is an exciting method of examination. Tomorrow we are going to have a seminar and I will perform OCT. What you are saying is a high disadvantage because if you follow up the same patient on different devices, you are going to obtain completely different data on blood circulation in the retina. That is why for now there is no standardization of such indexes and such devices because each device has a different algorithm of calculation and the results are completely different. So we are grounding on clinical classification. Thank you. There are pretty many data that, namely, absence of perfusion is more prognosively correct that perforation is going to take place more than FAC. Yes, I agree with you, but for present, perfusion may be assessed by different methods like fluorescent angiography, method of OCT angiography, but it is highly significant to assess the area of the lesion along with the stage of the lesion. If you have, for example, in thrombosis of the central vein, there is the area which exceeds 10 times the norm, exceeds the norm 10 times, then it bears higher risk. So we are going to examine the fundus in full and the eye in full. Another question to Alexandra Vladimirovna, maybe? Or can I ask a question from Galina Ivanivna? Galina Ivanivna, please, don't stand up. Tell me, please, do you deal with mycobacteria? What do you do if you suspect mycobacteria? do you deem it necessary to perform scraping in patients' primary referral? And when do you add insulin in order to initiate epithelialization when it is required in order to add corticosteroids, in which conditions? As to mycobacteria, we have not had these cases, but in some cases we cooperate with specialized laboratories, but never have we faced this mycobacteria. What was the second question? Yes, insulin. As a rule, we begin the scraping every time in order to obtain the qualitative and quantitative analysis of flora. If required, we conduct antiseptic and antibacterial therapy. If we see that there is no healing, the indicators of the infection are destroyed, then are not destroyed, then we use insulin. Probably more, we are more confident about it than if we used blood serum. Unfortunately, the speaker is without the mic. Yes, the antibiotic therapy in viral keratitis. When should we start? And how long should it take place? If we don't see infiltration, inflammatory infiltration, we do not prescribe antibiotics at all, because if it is superficial antiseptic, antiviral therapy, local antiviral therapy is enough. If it is stromal keratitis, antibiotics is not indicated at all. If we have clinical symptoms that make us suspect this case, then yes, then we do use it. But I was speaking about clinical picture. Unfortunately, the speaker is speaking without the microphone. Once we had the patient with confirmed acanthamoeba from the sample taken in the operational theater. Any method has a certain percentage of mistake risk, and there are researchers who study these cases, and every expert has to be experienced. So I would like to protect, so to say, the doctor who referred the patient to you with diagnosis chronic thrombosis. I am really respectful, but none of the ICDs contains this diagnosis, because chronic thrombosis, from the clinical point of view, a doctor sees thrombosis, but it's but there is blood leakage, and such doctor knows the main thing, that there is something wrong on the fundus. That is why this doctor should refer such patient to you, to Professor Zborovska. I would do the same. Yes, we are all working in the medical system of Ukraine, and we have to establish the diagnosis according to ICD. That is fair. Fine. Any other questions? If not, we are going to finish our section. We are grateful to all the reporters. Thank you for your questions as well, and let us switch to the next session.
Кліп, і готово. Кліп, 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 і готово. Кліп.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що Майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуальним в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників і ми займаємось такою складною.
Офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології. Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуально в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників, і ми займаємось такою складною патологією, як овеїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології. Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських